Hello students, welcome to another video. This time is concepts of care for patients with musculoskeletal conditions. Please focus on the following concepts: bone mineral density, dual X-ray absorptiometry, which is your DEXA, Dupuytren contracture or deformity, ganglion, hallux valgus deformity, osteomyelitis, plantar fasciitis, Payet disease, and we're going to have a segment in which we're going to talk about bone cancer or cancer of the bones. Okay, well, we are going to get deep into this lecture. Also, we're going to start analyzing the mobility, infection, cellular regulation, and pain. We're going to talk about that related to all the diseases we're going to cover today. So musculoskeletal conditions include diseases of cellular regulation, osteoporosis, and cancer, bone tumors, bone infection, and a variety of deformities and syndrome. When we talk about cellular regulation, we are talking about many soldiers. We are talking about the participation of osteoblasts, osteoclasts, other factors that are going to promote this regulation, like calcitonin, PTH, estrogen, the participation of calcium, vitamin C, vitamin D. So those are going to be interrelated to cover cellular regulation. So osteoporosis is the first topic we are going to cover. And because of that, I want to repeat the video we saw in the previous chapter, because it's good for you to refresh and to it's a good start to cover this topic, osteoporosis.
The human skeleton gives the body its shape and provides physical support for the systems contained within. It also forms part of the musculoskeletal system that enables us to move. The structure of bone is optimized so that it is strong but relatively lightweight. The interior of bone is composed of bone marrow. It is surrounded by two major types of bone tissue: cortical bone, or the hard outer shell of bone, and trabecular bone, the spongy-looking center. The amount of each type of tissue in bone is dependent on the function of that bone. The basic unit of cortical or compact bone is the osteon. It is composed of successive concentric lamellae. This structure contributes to bone strength by resisting bending. Cells called osteocytes are distributed within the concentric lamellae. Osteocytes form a complex network that is thought to be important in maintaining the viability and structural integrity of bone. At the center of the osteon is the Haversian canal. These canals contain blood vessels and nerves. The blood vessels within bone facilitate the exchange between osteocytes and the blood. Trabecular bone is present in the interior of some bones and resists compression. Osteocytes are also contained within its structure and again play an important role in sensing local changes in strain. Trabeculae are covered in a layer of flattened lining cells that are thought to be involved in the dynamic process by which bone is formed and broken down. Bone marrow is found within the interior of bones. The surrounding trabeculae and vascular network provide structural support, nutrition, and a waste removal system for the heterogeneous group of cells found within this space. Bone marrow is a site for hematopoiesis, the process by which the cellular components of blood are formed.
Thank you very much for that video. So the leading role is the trabecular area in the bone, okay, which is called the spongy bone, right? And that is going to be affected by the osteoporosis, okay? So let's continue with this and okay. Osteoporosis is a chronic disease of cellular regulation. We know that, in which bone loss causes significant decreased density and possible fracture. A silent disease because the first sign of osteoporosis in most people is diagnosed after a fracture. So when they are going to the X-ray, the examination is going to tell you that the density, is not good. So it's having low density. 50% of all postmenopausal women will have a fragility fracture caused by osteoporosis, sometimes referred to as bone attack. In their lifetime, this is going to happen, right? 25% of men over 50 years of age will also have an osteoporosis-related fracture. This risk is especially high for women of color and Asian, Pacific Islander women when compared with white women. So postmenopausal women are having less estrogen production by the ovaries. So the estrogen we review in the previous chapter, estrogen is related to osteoblast. B as in birth, osteoblast, new cells, okay? So that estrogen is not produced anymore. That's why we are having the risk of having this low bone density. Osteomalacia is loss of bone related to lack of vitamin D, which causes bone softening. Vitamin D is needed for calcium absorption in the small intestine. As a result of vitamin D deficiency, normal bone building is disrupted and calcification does not occur to harden the bone. So having said that, the first thing is that you need to know that vitamin D, let's put it this way, is the key that opens the door for calcium absorption. You can take as much calcium as you want, but if you don't have enough levels of vitamin D to be absorbed in the intestine, osteoporosis can occur or any other disease related to the bones. Okay, vitamin D is the door that opens the door for calcium to be absorbed in the intestine, okay, in the small intestine. Okay, osteoporosis and osteopenia, loss of bone mass, and let's remember that osteopenia is the first stage before osteoporosis, okay? So osteopenia is loss of bone mass occur when osteoclastic bone resorption, and we know that osteoclastic, the C, osteoclastic, relates to cut, right? To destroy is bone destruction, and osteoclastic activity is greater than osteoblastic bone building activity. So in osteoporosis, the amount of destruction is greater than the amount of bone creation, okay? The result is a decrease in bone mineral density. BMD, from now on, bone mineral density, is the amount of mineral that determines bone strength. It peaks between 25 and 30 years of age. Before and during that peak years, osteoclastic activity and osteoblastic activity work at the same rate. So there is destruction, production of bone cells. After the peak years, meaning after 30 years, osteoclastic activity exceeds bone building activity and bone density decreases. So osteoclastics take the lead in bone destruction, and osteoblastic is more slow in their production. BMD decreases most rapidly in postmenopausal women as zero estrogen levels diminish, as I mentioned before. Estrogen, although estrogen does not build bone, it helps prevent bone loss because estrogen has a direct effect on osteoblastic. Trabecular or cancellous spongy bone is lost first, followed by loss of cortical compact bone. So we have inside of the bone marrow, and then following that, outside we have the trabecular, which is the spongy part, and then following that outside is the cortical bone, the compact bone. So trabecular is the one that is going to be affected first. The hip, wrist, and spinal column, hip, wrist, and spinal column have the highest amount of cancellous bone, meaning the hip, the wrist, and the spinal have the highest amount of trabecular, the hip, the wrist, and the spinal, and therefore the most likely to fracture first. So we are having our old patients right there in high risk just by aging, the hip and the spinal column and the wrist. Okay, so those patients that are going for shopping and they don't have the shopping cart and they are carrying, the shopping bags and they have 70, 80, right? Their wrist is going to be in risk for fractures. Standards for the diagnosis of osteoporosis are based on BMD, bone mineral density testing that provides a T-score for the patient. I'm going to submit, you will receive in the supplemental file a rule, it's a table in which you can see how the T-score is classified. A T-score represents the number of standard deviation above or below, designated with a minus sign. The average bone mineral density for young, healthy adults. The T-score in a healthy 30-year-old adult is 0. So 0 is healthy. Osteopenia is present when the T-score is -1 and above -2.5. So 0 is going to be in the middle. On the right side, you have +1, +2, +3. And on the left side, you have -1, -2, -3. So osteopenia is present when the T-score is -1, but is above -2.5. So it's going to be from -1 to -2, more or less, right? Or -2.4. Osteoporosis is diagnosed in a person who has a T-score at a lower than -2.5. It's going to be 2.5, -3, -3.5, right? Osteoporosis, and just for the people who didn't watch the first video, just want to mention that we're going to do a refresh. Estrogens stimulate osteoblastic activity. We mentioned that already. Okay. And inhibit PTH. So they stimulate the creation of new bone cells, and they also inhibit PTH, meaning the PTH is parathyroid hormone. For those of you who didn't watch the first video, I told you to remember this, like parathyroid is going to tell the bone, put that calcium out from the bone in the serum calcium. Okay, so we are talking about two different areas, the bone and the serum calcium. So estrogen is going to inhibit the parathyroid, is going to inhibit the release of calcium from the bone to the serum in order to have healthy and good bones. Okay, so when estrogen levels decline at menopause, women are susceptible to low serum calcium levels. We're talking about the serum calcium levels now, with increased bone loss, osteoporosis. Okay, so we know that osteoclast is causing metabolization, kind of causes the release of calcium into the serum, and osteoblast is the one who give birth to new bone cells. There is a video here and is also in the supplemental file if you want to watch it again. Also, this video was given in the first chapter in the previous video related to this musculoskeletal system. So we know already what is osteoclast and osteoblast. And we spoke about the T-score. Osteoporosis can be classified as generalized or regional. Generalized osteoporosis involves many structures in the skeleton and is further divided into two categories, primary or secondary. Primary osteoporosis is more common and occurs in postmenopausal women and in men in their 7th or 8th decades of life. It's kind of natural osteoporosis, right? Because of aging. Secondary osteoporosis may result from other medical conditions such as hyperparathyroidism, right? So the parathyroid is gonna work too much and is going to tell the bone, put that calcium out of the bone, causing osteoporosis, and increasing the serum calcium levels, okay, to make it clear. So we have the hyperparathyroidism, long-term drug therapy like steroids, or prolonged decreased mobility, such as that seen with a spinal cord injury. So patients that are having a sedentary life are a high risk of osteoporosis. Remember that all this activity, production, destruction, and the cycle is going to be affected after 30 years of age. Okay, table. Differential features of osteoporosis and osteomalacia. And let's remember that osteomalacia is related to vitamin D, right? That's the most important. So it's related to vitamin D. Okay, so let me go down. And you have the primary etiology. Osteoporosis is lack of calcium and estrogen or testosterone, right? Because those are having an effect in the osteoclast or osteoblast. Osteomalacia basically is the lack of vitamin D. Okay, radiographic findings in osteoporosis, you're going to see bone loss, fractures, osteopenia, and in osteomalacia, you're going to see fractures, right? Okay, so let's go to best practice for patient safety and quality care, assessing risk factors for primary osteoporosis. Let me make a note here. I want you to compare this table with the previous chapter table in which we were talking about alkaline phosphatase, LDH, and all your liver functions also. So you have to be familiarized with this because probably, and I really forgot, I'm sorry, to put this as an NCLEX alert. This is going to come in NCLEX. They are going to tell you there is a patient, the presentation with a recent fracture, and probably they are going to tell you, you know, the blood work reveals alkaline phosphatase, this level, you know, LDH, this level, and so you need to be familiarized in order to identify if it's osteoporosis or osteomalacia, right? So they are going to give you the full presentation and they are going to mention the levels, vitamin D, calcium, and so you need to be very familiarized with these labs. Is an NCLEX alert. Okay, so let's continue. So in case of primary osteoporosis, what is going to happen is that we are going to assess, I don't know what's going on with my computer tonight, but anyway, you need to remember that that is an NCLEX alert. For primary osteoporosis, you're going to assess for non-modifiable risk factors. For example, you are going to check the older age. Over 50 years of age, that's a non-modifiable, but the most important is menopause, parental history of osteoporosis, especially the mother, if it's white or Asian ethnicity. Those are factors that you need to consider. Eating disorders, rheumatoid arthritis, history of any fracture after age 50. So this is a refresh from the previous chapter. Remember that primary osteoporosis is more common and occurs in postmenopausal women and in men in their 7th or 8th decade of life. Okay, assess for life potentially modifiable risk factors, all of the following, right? Low body weight, so the patient can actually gain weight and practice sport, can increase the intake of calcium and vitamin D. Probably they can take some estrogen, stop smoking. It's not reduce smoking, it's stop smoking, okay? Either active or passive. High alcohol intake. In this sense, the patient can reduce the alcohol intake. You need to assess for what therapies, what drug therapies, especially steroid, what is the nutrition, lack of physical exercise, or sedentary life, right? So this is good to know. All these in yellow here are good to know. You need to breathe, live, and sleep thinking about these factors. Regional localized osteoporosis, an example of secondary disease, can occur when a limb is immobilized related to a fracture, injury, or paralysis. So there is a reason why the patient has that limb immobilized. Decreased mobility for longer than 8 to 12 weeks can result in this type of osteoporosis. So think about all those patients that are having a car accident and they ended up being on a vegetal state, right? So not only pressure ulcers, but also osteoporosis. And those of you who wants to work in ICU, you need to think about this. And basically, you need to follow not only the patient care physically, but your lab work is every day, every hour. You need to be on top of that. Okay, etiology and genetic risk. Primary osteoporosis is caused by a combination of genetic, lifestyle, and environmental factors. Let me repeat. Primary osteoporosis is caused by a combination of genetic, okay, maybe the mom was having osteoporosis, lifestyle, meaning sedentary life, lack of nutrients, and environmental factors, okay, could be passive smoking. Okay, so genetic factors associated with osteoporosis. Many genetic changes have been identified as possible causative factors, but there is no agreement about which one are most important or constant in all patients. For example, changes in vitamin D receptors gene and calcitonin receptor gene have been found in some patients with the disease. This is a very interesting piece of information. Hormones, tumor necrosis factor, interleukins, and other substances in the body help control osteoclast in a very complex pathway. And here there are other participants like nuclear factor kappa B. Actually, the full name is receptor activator of nuclear factor kappa B. Osteoprotegerin, and these factors understand more about the activity of osteoclast in metabolic disease. All of them are participating in the activity of osteoclast. How the bone is rapidly broken down. These physiologic changes has contributed to the development of new drugs to manage osteoporosis. So the kappa B, the osteoprotegerin, the osteoclast, and interleukins, tumor necrosis factors, they are all together being analyzed in order to create new drugs, and they did it. So what is kappa B, Dr. Matalana? Kappa B is a known regulator of gene expression. Okay. Osteoprotogenic is a member of the tumor necrosis factor receptor family, and is a cytokine traditionally linked to the regulation of bone remodeling. Cytokines, we know that cytokines are a broad and loose category of small proteins important in cell signaling. So when we mention cytokine, you immediately think about cell signaling. And interleukins are a group of cytokines, secreted proteins and signal molecules. Also, you see, also interleukins are giving signals, but they are expressed and secreted by white blood cells, leukocytes, as well as some other body cells. Okay, so at least little by little, you are gonna get into the habit of listening this terminology, and little by little, you are going to absorb this knowledge. Don't be overwhelmed with this area. The biochemistry of the body. Don't be involved with that. Don't be scared. Patient-centered care, gender health, primary osteoporosis most often occur in women after menopause, yes, or after removal of both ovary as a result of decreased estrogen levels. We have been repeating this over and over again, so if I ask you about this, I'm expecting you to know this perfectly, because we repeat this like 10 times. Obese women can store estrogen in their tissues for use as necessary to maintain a normal level of serum calcium better than thinner women, and are therefore less likely to develop osteoporosis and resulting in fractures. Okay, men over 50 years of age also develop osteoporosis as they age because their testosterone levels decrease. And we just saw a few minutes ago that estrogen and testosterone play a crucial role in osteoblast activity, right? Testosterone is the major sex hormone that builds bone tissue. Very good. Good to know. That's good to know. Good to know. The relationship of osteoporosis to nutrition is well established. Okay, for example, excessive caffeine in the diet can cause calcium loss in the urine. Let me repeat this again. I am very happy to repeat this because I've seen you guys with a lot of coffee around you. Excessive caffeine in the diet can cause calcium loss in the urine. A diet lacking enough calcium and vitamin D stimulates the parathyroid gland to produce parathyroid hormone. So if you don't get your calcium and vitamin D, you are going to stimulate the parathyroid hormone. Parathyroid hormone triggers the release of calcium from the bony matrix to the serum. Okay, activated vitamin D is needed for calcium uptake in the body. Malabsorption of nutrients in the small intestine also contributes to low serum calcium levels. Let me stop here. Malabsorption of nutrients in the small intestine, meaning if you are having problem of gastritis, which happens to be in the upper part of the stomach. Because absorption starts from the mouth to the anus, right? That's absorption. That's the gastrointestinal. So if you're having constipation, you are having problems with diarrhea, you are having gluten intolerance issue, those little things, or maybe chronic GI bacterial in the GI, or you have problem with the microbiota in the gastrointestinal area, you don't take your probiotics, right? Those are causing problems of malabsorption. So anything you eat, right, is going to be a waste because you are not absorbing. If you're having inflammation, distended abdomen, right, those are causing malabsorption. So even if you take your vitamin D, your calcium, if you're having issues in your gastrointestinal, malabsorption is going to happen and you're taking your supplements and it's going to be a waste. Okay? So institutionalized or homebound patients who are not exposed to sunlight may be a higher risk because they do not receive adequate vitamin D for the metabolism of calcium. Okay, this is happening here in the states that are in the east part of the country, also the Nordic country, right? Canada. If we analyze the situation in Florida or states that are having a lot of sunlight, they don't have these problems. Basically, everybody in New York is having low vitamin D issues and they don't go for checkup. So that's your homework. Your first homework is to go to your primary care and ask for your vitamin D levels and calcium levels and vitamin C levels, okay? Calcium loss occurs at a more rapid rate when phosphorus intake is high. So we know in the serum, phosphorus and calcium, they have an inverse relationship. This, okay, chapter 13, whatever. People who drink large amount of carbonated beverage, all of you who are getting your diet, ginger ale, diet, Coke, or even your regular Coke each day, over 40 ounces, which is a liter and 200 mls, okay, are a risk for calcium loss and subsequent osteoporosis, regardless of age or gender. Thanks God McDonald's stopped that offer that for $1 you can get a large Coke, okay, and that large Coke was certainly almost a gallon of carbonated beverage, right? Thanks God they are not having, because this is causing a problem in the absorption of calcium and vitamin D. I don't know how the government is allowing these companies to sell these products, honestly. Protein deficiency may also affect cellular regulation because 50% of serum calcium is protein bound. Protein is needed to use calcium. However, excessive protein intake may increase calcium loss in the urine. For example, people who are on high protein, low carbohydrate diets such as Atkins diets may consume too much protein to replace other foods that are not allowed. And certainly another diet that is similar to Atkins, a little bit more restrictive, is the ketogenic diet, okay? Keto diet, in which patients are eating huge amounts of proteins and they are eating basically no carbohydrates. Issues and diagnosis and treatment of osteoporosis. Body build, weight, and race ethnicity seem to influence who gets the disease. So it's not only the lifestyle, but also is the race and ethnicity. Osteoporosis occurs most often in older, lean-built white women, particularly those who do not exercise regularly. However, dark-skinned individuals are at risk for decreased vitamin D, which is needed for adequate calcium absorption in the small intestines. In the previous chapter, we mentioned that Black people, they have a good bone density and decreased risk for osteoporosis. But we need to add this factor. If dark-skinned individuals are at risk for decreased vitamin D, and we know that vitamin D, lack of vitamin D is gonna cause a problem in the absorption of calcium, then they are going to have problems with osteoporosis. Dietary preferences or intolerances, sun avoidance, or the inability to afford high nutrient food may influence anyone's rate of bone loss. For example, many non-Hispanic Black often have lactose intolerance and cannot drink regular milk or eat other dairy-based food. As an alternative, lactose-free milk, almond milk, or soy milk provides calcium, although these types of milk may be cost-productive. Yes, there are some markets in which these nutrients are being sold and they are not as expensive. I don't like to give, I don't like to mention brands. Probably I will do it in class. But also there are some techniques that we can learn to prepare our own almond milk, even flaxseed milk, which is really cheap. In order to cover those nutrients. Okay, please I'm gonna write a reminder here. I'm gonna teach you how to do that so you can teach your patients. Osteopenia and osteoporosis. Although postmenopausal women are the high risk, male and female veterans often have osteopenia or osteoporosis, which may be diagnosed after a low trauma fracture. Those are things that we need to consider as well. So osteoporosis, to prevent fractures and disability related to osteoporosis, these objectives have been outlined. First, reduce the proportion of adults with osteoporosis, increase the proportion of adults who get screened for osteoporosis, reduce hip fracture among older adults, increase the proportion of older adults who get treatment for osteoporosis after a fracture. So these are four factors to prevent disabilities related to osteoporosis. The focus of evidence-based osteoporosis prevention at any age is to decrease modifiable risk factors to promote patient safety. So we need to decrease the modifiable risk factors to promote patient safety. And which one are the modifiable risk factors? So these are the ones: low body weight, thin build, we need chronic low calcium and vitamin D intake, so we need to increase vitamin D and calcium. Maybe taking estrogen, stop smoking, either active or passive. If you're a passive, try to get away from people around you that is smoking. Stop alcohol intake. 2 or more drinks per day. Honestly, we should stop drinking alcohol, for not only for osteoporosis, but also we're going to see in future lectures about different, for example, the GI system, how bad is alcohol for our body. Reduce the amount of drug therapies like steroid if possible. Get a better nutrition and increase the mobility. Stop being sedentary and stop dancing, moving, walking, riding your bicycles. Okay, so the focus is to change the modifiable risk factors. Teach patients who do not include enough dietary calcium examples of best food to eat, such as dairy products and dark green leafy vegetables. I gave you in the previous chapter a supplementary file with articles and websites where you can see where else you can find calcium in the food, fruit and vegetables. Teach the patients to read labels, explain the importance of sun exposure. This is related to vitamin D. And also we can get adequate vitamin D in the diet, meaning your supplements, right? Teach people at high risk for bone loss the importance of smoking cessation, weight loss, and avoidance of excessive alcohols, and all the previous factors that we mentioned. Important is weight-bearing exercise, such as regularly scheduled walking, to avoid activities that cause jarring, such as horseback riding and jogging, to prevent potential vertebral compression fractures, right? Remind all postmenopausal women and men over 50 years of age to request bone loss screening from their primary health care provider, meaning go to the primary care and ask the doctor for your bone mineral density exam, your DEXA, right? Although their risk is less than on whites, be sure to teach people of color than those of Asian descent to have bone loss screening by no later than 50 years of age. And that's good to know. Be sure, nurses, to increase calcium and vitamin D in your diet. I've been mentioning this for 2 chapters also. So the estrogen, postmenopausal factor, vitamin D, calcium, it's gonna come in the test. It's not possible that you can fail that question, okay? Because we repeated this over and over again. So get your vitamin D, your calcium, regular exercise, and to the extent possible, follow a healthy lifestyle to prevent osteopenia or osteoporosis. If you are postmenopausal or a male over 50 years of age, seek screening for bone mineral density. If you have experienced either a high or a low trauma fracture, be aware that they are high risk for future fractures and should seek post-fracture treatment and monitoring. Okay. Let's talk about assessment. We have to conduct our history. We are going to use our old cards mnemonic. Physical assessment. We are going to inspect the vertebral column, the classic Dowager hump in the kyphosis, you're going to see that in the older patients. They may state that they have gotten shorter, perhaps as much as 2 to 3 inches, which is a lot. Take or delegate the taking of height and weight measurements and try to create a baseline, right? So you have somebody who was, I don't know, 5'8" in 2020 and right now is 5'3" in 2024, and the patient is 68 years old. So review that if the patient is having kyphosis, for example, right? Fall prevention, the Joint Commission National Patient Safety Goal specify the need to reduce risk for harm to patients resulting from fall. Hospital and long-term care facility have risk management programs to assess for the risk of falls. When we work in hospital and long-term care facilities and you see these protocols that are put in place, means that there is a mandatory state government policy behind that. Okay, so that means if you don't follow the policy, your license is in risk. Okay, hospital acquired condition, hospital acquired infections are having a federal, state, government, whatever policies. You need to follow that. Okay, for patients at high risk, communicate this information to other members of the healthcare team using color armbands, posted signs, or other easy to recognize methods. The patient may have back pain, which often occurs after lifting, bending, or stooping. Pain is worse when with activity and is often reduced by rest. Okay, so that's a sign. Pain is worse with activity and is often reduced by rest. Back pain accompanied by tenderness and voluntary restriction of spinal movement. Back pain accompanied by tenderness and voluntary restriction of spinal movement suggests one or more compression vertebral fractures. This is very important. You nurses in general, our job is to assess, to observe. Our job is also to give medication, cross medication, put the IV, put the information in the software to record all signs and symptoms, to complete the documentation. But our first job is to assess and to observe the patient physically. Okay, We are not there to complete a form in the computer and to crush and just to crush medication. No, that is not our job. Our job first is to observe, to be compassionate, and to observe patient activity and adverse events in case they exist. So mobility restriction and spinal deformity may result in constipation, abdominal distension, reflux esophagitis, and respiratory compromise in severe cases. So we are going to give a medication to the patient. When we receive the report, when they pass the baton to us, we are taking our blood pressure, we are checking physically, visually, abdominal distension, we are going to check for respiratory issues. The most likely area for a spinal fracture is between T8 and TL, okay? And that area is related to the bowel and the bladder, T8 and L3, I'm sorry, the most movable part of the vertebral column. Fractures are also common in the distal end of the radius, which is the wrist, and the upper third of the femur, the hip. Okay, so psychosocial assessment, women associate osteoporosis with menopause, getting older, and becoming less independent. Quality of life may be further affected by persistent chronic pain, insomnia, depression, and fear of falling. In my experience, women, postmenopause women that are in the right weight, their mental health is much better. Depression is not an issue. Insomnia is a little bit of an issue, and the fear of becoming dependent is not there because they have the right weight, the appropriate weight. They are able to walk, they are able to do their activities of daily living, and mentally they are okay. The amount of cholesterol, sugar is okay. So we need to look first to, if we see a patient that is overweight or obese, we need to work with the patient in order for them to lose weight, and everything else is gonna fall into place. Okay, because osteoporosis poses a risk for fracture, teach the patient to be very cautious about activities. The threat of fracture can create anxiety and fear and result in a further limitation of social and physical disabilities. Okay, laboratory, serum calcium, vitamin D levels should be routinely monitored at least once a year for all women and for men older than 50 who are at high risk for the disease. Serum calcium should be between 9 and 10.5, we know that, and vitamin D, the total 25 hydroxy vitamin D, D2 plus D3 levels should be between 25 and 80. So this is good to know. I will tell you that if I have a patient that is coming to the office with the vitamin D level of 30, right, based on the book, it should be between 25 and 80. If this patient is coming with a vitamin D of level 30, in theory it's normal, right? But we have to look for that patient to be in the upper level. So based on the book, because I've seen other laboratories referring to vitamin D between 30 and 100, 30 and 120, depends on the laboratory. So I would say more than 70. That's a good level of vitamin D. Now, vitamin D, which one? Vitamin D2 or D3? I will strongly recommend D3. Okay, I will tell you in class how you can memorize these three. This vitamin D3 basically is like the three makes me think about the little ears of any pet, right? Like a little bunny. So 3 is an inverse figure of the bunny. So those D3 is coming from animal. Is coming from animal, so it's better. What else I was gonna tell you? First, so if that patient is coming with a level of 30, 1 year follow-up is not enough. Probably you need to make sure that the patient is gonna go you know, to the proper level. So at least twice a year. At least twice a year. First thing, nurses, go and check your calcium and vitamin D. The nurse is proving health teaching to a postmenopausal client is providing, right? About osteoporosis prevention and screening. Which statement by the client indicates the need for further teaching? So you have, I'll try to eat more food high in calcium, like dairy products. That's good. I join a group of co-workers who take a walk at lunchtime. That's excellent. I sign up for a virtual smoking cessation program. Excellent, with my partner. Notice here she said cessation program. She doesn't say smoking reduction. And then I'm planning to have my DEXA scan next week because I should get one every year. And that's the right answer. In that sense, she needs further teaching because DEXA is every 2 years. Okay, so that's good to know. Imaging assessment. We have the conventional X-ray of the spine and long bones show decreased bone density, but only after a large amount of bone loss had occurred. Fractures can also be seen on X-ray. So when the bone loss is severe, the X-ray is gonna show it. All menopausal women and men age 50 and older should be evaluated for osteoporosis risk to determine the need for BMD testing and or vertebral imaging, bone mineral density, and that's good to know. Screening starts 50. The most commonly used screening and diagnosis radiographic test for measuring BMD is your dual X-ray absorptiometry, your DEXA. The spine and hip are most often assessed. Spine and hip are often assessed when a central DEXA is performed. If a spinal deformity is present, the wrist is also going to be assessed. When there is a spinal deformity, then the wrist will be assessed. DEXA is a non-invasive painless scan that emits less radiation than a chest X-ray, believe it or not. Height is measured before a DEXA scan. The patient stays dressed but is asked to remove any metallic object, such as belt, buckles, coin, keys, or jewelry. The results are displayed on a computer graph and a T-score is calculated. Patients who have osteopenia or osteoporosis usually get a follow-up every 2 years. If the patient goes to a CT-based absorptiometry, this test measures the volume of bone density and strength of the vertebral spine and hip, and the peripheral QCT scan measures the same at the forearm or tibia. High resolution peripheral QCT of the radius and tibia provides additional information of bone structure and architecture. These tests are predictive of spine and or hip fractures in women. However, they require greater amount of radiation when compared with a more traditional DEXA, and that is the reason why I'm taking my time and letting you know this. So you have DEXA has less radiation, chest X-ray has more radiation than DEXA, and this type of CT test, the high resolution PQ-CT, also are having much more amount of a greater amount of radiation. Vertebral imaging can be performed using lateral spine X-rays or lateral vertebral fracture assessment, which is available as part of most DEXA system. So for this particular imaging, who qualifies for this exam is all women age 70 and older and all men age 80 and older if bone mineral density is less than or equal to a T-score of 1. And then you have all the description of all the patients that qualify for this particular test. The most promising imaging test for diagnosis bone disease is the use of MRI to assess bone marrow composition, and MRI does not involve radiation and can be used to view bone in ways that other techniques cannot. Fat marrow content, sometimes referred to as bone marrow adipose tissue, is higher in patients with bone loss compared with those with normal BMD, normal bone mineral density. So the priority that we need to cover in terms of patients with osteoporosis or osteopenia is potential for fracture due to weak porous bone tissue. And we need to avoid fractures by preventing falls, managing risk factors, and adhering to preventive or treatment measures for bone loss. So what are we going to do? Nutrition, lifestyle changes, and drug therapy, assessment, observance, and we are going to use them sometimes to reduce bone resorption, which means bone distraction, and form new bone tissue. Then nutritional therapy, we know already, good amount of calcium, vitamin D, to avoid excessive alcohol, caffeine. For those who are lactose intolerant, you can choose between a variety of soy, rice products that are fortified with calcium and vitamin D. Also, these two are present in many fruit juices, bread, and cereal products. Again, I am remembering you that I gave you a website in the supplemental material from the previous chapter, so you can find these websites. Be sure to evaluate if the individual can afford to purchase these expensive foods and beverages before nutritional health teaching. And just remember that the promotion of a single nutrient will not prevent or treat osteoporosis, meaning that not because the patient is taking a lot of vitamin D, okay, first of all, if the patient does not know his vitamin D levels, he cannot prescribe himself vitamin D. So, okay, I'm taking a lot of vitamin D. Yes, but you are not taking your calcium, you are not taking your vitamin C, you are not, you know, and you have to do all of them together in order to see progress, okay? Lifestyle changes, exercise is very important. Straightening the abdominal back muscles, abdominal muscle tightening, deep breathing, exercise for extremity muscles, swimming and yoga provide overall muscle exercise. General weight bearing exercise program like walking for 30 minutes 3 to 5 times a week is good. It's not like 30 minutes is not enough. Yes, it's enough for somebody who is being sedentary. 30 minutes is a lot. And then you can increase, right? Also to avoid tobacco, alcohol, remind women not to consume more than 1 alcoholic drink per day, and men no more than 2 alcoholic drinks per day. Drug therapy. So we have evidence shows that drug therapy should be used for menopausal women and men age 50 and older when the bone mineral density T-score for the hip or lumbar spine is below or equal to minus 2.5. So when we get to that level is when the medication is going to be prescribed. Okay, or when the T-score is minus 1.5 with risk factors or previous fracture. So you have biphosphonate estrogen agonist, your selective estrogen receptor modulator, your parathyroid hormones, your receptor activator, the kappa, I don't remember the name, the kappa B inhibitor, sclerostin inhibitor, or a combination of several drugs to prevent osteoporosis. Biphosphonates are the most common drugs used for osteopenia, yes, and are considered anti-resorptive drugs, meaning they inhibit the destruction of the cell bones because they slow bone resorption by binding with crystal elements in bones, especially spongy, cancellous bone tissue, the tissue in the trabecular space. Paget disease and hypercalcemia yes, are treated also with biphosphonates. Paget disease is a chronic, slowly progressive skeletal metabolic bone disorder that causes rapid bone destruction and reformation, causing bone pain, arthritis, fractures, and deformities. So we have a very nice article for you to read about the medications. A newer drug class is rank ligand receptor activator of nuclear factor kappa B ligand inhibitors such as denosumab. So we were talking about these nuclear factor kappa B medications. We are talking about denosumab. This drug is given subcutaneously twice a year by a healthcare provider and work to prevent bone loss by inhibiting osteoclastic mediated bone resorption. So you see, when we mention osteoclastic now, you understand what is the activity osteoclastic because we have taken our time in explaining this. Okay, let's see the drug therapy and stuff that I really want you to remember and focus. So in the category of drug, we have calcium and vitamin D3 may be taken separately or in combination. You really need to know the whole table. Okay, you take a third of the daily dose at bedtime because no weight-bearing activity to build bone occurs while sleeping. To clarify, that's good to know. It's going to come in the exam. A third of the daily dose should be given at bedtime of calcium because calcium is most rarely utilized by the body when the client is fasting and immobile. So that happens when the patient is close to the bedtime. Okay, for calcium, you need to drink a lot of fluids, assess for urinary stones before giving calcium, okay, monitor calcium level, observe for hypercalcemia, such as calcium deposits. There are little deposits that are formed close to the joints or any part in the body, okay? Teach patients to check with their primary healthcare providers about recommended dose to take. Now we have the biphosphonates. The most popular are alendronate and cellodronic acid, but this one, the last one that I just mentioned, is given IV. The alendronate is going to be given oral, right? This is good to know. This is NCLEX maximum alert bisphosphonates. Why? Because there are too many factors we need to consider, right? For example, we don't want to take this drug on an empty stomach first thing in the morning because we want to prevent esophagitis. It's a question of safety. Biphosphonate is related to safety measures, nurses, okay? Esophagitis is not a joke. Remind patients to take drug 30 minutes before food, drink, and other drugs to prevent interactions. So the stomach is going to have some food. Instruct the patient to remain upright, sitting or standing for 30 minutes after taking the drug to help prevent esophagitis. So it's all about preventing esophagitis. Instruct the patient to have a dental examination before starting the drug because it can cause jaw and maxillary osteonecrosis. So there you go. You have two already. You have prevention of esophagitis and prevention of osteonecrosis. If the patient is taking aspirin, you cannot give this drug because he can have bronchoconstriction. So the patient is going to have respiratory issues. For IV drug, infuse over 15 to 30 minutes to prevent rare complications such as atrial fibrillation, which is another important factor to consider. For IV drugs, check the patient's serum creatinine before and after administering the medication because it can cause renal insufficiency and acute kidney injury. So right there, your biphosphonates are causing, we have to prevent esophagitis, we have to prevent osteonecrosis, we have to prevent atrial fibrillation when we are giving the zoledronic acid IV, and with this same drug, we have to prevent, we have to measure, we have to look, observe, check our serum creatinine before and after administering the medication because it can cause renal insufficiency. We don't want to cause any problem. And also pay attention to bronchoconstriction if the patient is taking aspirin. For estrogen, let's prevent thromboembolism and monitor your liver function test. And for this receptor activator, the kappa B inhibitor, the denosumab, you need to teach the patient to report signs and symptoms of infection, a common adverse event. This is very important for you. These medications, these drugs has a lot of adverse events and you need to master this. This is NCLEX maximum alert, okay? Remember that musculoskeletal issues are causing a lot of expenses in healthcare systems. So we need to monitor this and we need to master these medications and all the interventions, patient education related to this. And there is another drug called romosozumab. I am just providing the information. I haven't worked with this. A patient who have had a stroke or myocardial infarction in the past 12 months should not take this drug. Romosozumab is given only to women who can no longer become pregnant and should be avoided in any patient who has hypocalcemia. There is another medication that is working with the parathyroid hormone, teriparatide and abaloparatide, that are helping the parathyroid hormone to build bone and should not be used in the long term. So when we transition this patient to home care, are usually they are usually managed at home unless they have major fragility fractures, in which case they are going to be transferred to another facility. Remind patients to have follow-up DEXA scan as prescribed to determine the effectiveness of drug therapy. Patient's home is safe and hazard-free to help prevent falling. You need to monitor that the home is really safe. And for example, check the ramps instead of stairs or handrails near toilets and bathroom and showers. Self-management education help to prevent vitamin D deficiency, daily sun exposure, all the factors related to vitamin D and how to increase calcium and the proper way to take calcium. Also to supplement with good nutrition in case of lactose intolerant, to eat more rice and soy meal, tofu, which are very good substitutes of calcium, and also to be compliant with the drug therapy as prescribed by the primary care. Healthcare resources, we have Bone Health and Osteoporosis Foundation, and we have the Osteoporosis Society of Canada. These are, I've checked the websites, they are very good in providing information. And our patients, right now they love to be educated. They love, if you give them brochures, they will appreciate. If you give them websites, they will love it. They want to be on top of their diseases and conditions. Okay guys, let's make a break here. And when we come back, we're gonna talk of osteomyelitis and bone cancer. Stay tuned.